All right. So demystifying the tracheostomy, the reason I entitled the talk this way, honestly, my training in emergency medicine, I very much didn't feel prepared. I love my training, but when I encountered trach patients during my fellowship. And so, I think for everyone really, but definitely for myself, there's a fair amount of anxiety surrounding the management of trach patients. And that's for good reason. It's due to infrequent encounters. We do a whole lot of trachs in the United States. I think over 110,000 annually, probably a lot more than I know at least most countries in Europe. Yet the complication rate when we talk about fatal complications is not that high. So about 40 to 50% of patients who get a trach will have some sort of complication, and usually these are minor, right? So minor bleeding after the trach and kind of resolve with minimal intervention. But 1% of tracheostomy patients will suffer a catastrophic airway complication. And when we look at the critical care setting, about half of those airway-related deaths are associated and due to trach tube dislodgement. And so a lot of this talk actually is getting through and going over an algorithm with which we can sort of approach these tracheostomy emergencies. So let me see if I can advance here. So we're going to start out talking about basics. And, I certainly don't want to insult anyone. This was stuff that I think is really important to understand both the anatomy of the airway and the physiology of airflow. Because when you're in these scenarios and the SAT is 60%, you just want to know that you know this and start to rely on algorithms rather than thinking through, the physiology. So we're going to go a little over that. And then we're going to talk a little bit about equipment, not really specific brands, but more the components of the trach that are important to understand and manipulate. And when I give this talk, I always bring in this trach tube, which I have in my hands, and usually pass it around, which obviously I won't be able to do that. But we'll sort of talk through pieces of the equipment. And then finally, ending with the algorithm, or actually most of the talk is the algorithm, and I have a couple of cases depending on how time goes. So for us in the ICU, who gets a trach? And most of our patients that get a trach are those that fall in this upper left-hand corner, right? Those that need prolonged mechanical ventilation. And this definition in the literature is variable, but in general, these are patients that require like at least 3 weeks of mechanical ventilation for at least 6 hours a day. So those patients that sort of fail to wean from mechanical ventilation and then require a tracheostomy tube to sort of support them for a longer time in hopes of weaning. I think the next two sort of go hand in hand, right? So secretion clearance and airway protection. These might be patients who have a stroke or acute brain injury and can very quickly wean off the ventilator, but can't protect their own airway. And so they need assisted secretion clearance. And then finally, there's a cohort of patients that have airway obstruction. They may have had a laryngectomy like this gentleman in the picture, or perhaps they just have vocal cord paralysis or subglottic stenosis, or maybe a head and neck tumor that's obstructing their airway. And so you need to facilitate and sort of protect the airway with a tracheostomy tube. Now, I always make it clear, and our team always makes it clear to patients and their families, and I'm sure you do the same, that having a trach doesn't help you wean off the ventilator if you fall in that PMV group. It's not a way to sort of expedite weaning. It's simply a way to provide mechanical ventilatory support for a longer time period. So what it does do is gets patients more comfortable, right? They get all those lines and tubes out of their mouth and nose, and it establishes a definitive airway so that they can get out of the ICU, whether that's to a step-down ICU. For us, it's often to a long-term acute care hospital or an LTAC. So it's sort of the ticket out of the acute care setting. It does allow you to do better oral care and really sort of get patients more comfortable and off of sedation in many, many respects. So that's who gets a trach. So this is one of my favorite parts of this talk. The laryngeal handshake is a term coined by Rich Levitan, who is an airway expert. And I think this is so crucial for us as intensivists who support the airway of patients, both with intubation, cricothyrotomy, tracheostomy, is to sort of be able to palpate the landmarks of the airway. And so whenever I give this to our fellows, I make them do this. I can't see everyone's video right now, so I won't know if you're not, but I encourage you, and I will do it with you, to just take your hand and your thumb and your index finger and put it right under your mandible. And as you sort of squeeze midline, at the very top there, that first structure that's very rigid, that is your hyoid bone. It's pretty mobile. So then if you slide your fingers down just a little bit, there's a little depression there, which is your thyroid membrane. And then that large rigid structure, the next structure, if you go down further, is your thyroid cartilage. From there, if you take your finger midline and kind of ride down that thyroid cartilage, you feel this little depression where you can put the tip of your finger, there's a ridge below it. That ridge below it is the cricoid cartilage, and that little depression is the cricothyroid membrane. This is where we would perform a cricothyrotomy. Now, I want you to just take your chin down, keep your finger on that cricothyroid membrane and put your chin down. And you can feel it really shrink in size, and then totally extend your neck. And you can feel it really open up. And that'll become important when we talk about positioning with managing these airways. So that cricoid, that ridge at the bottom of that depression, which is the cricothyroid membrane, that cricoid cartilage is the only circumferential cartilaginous structure in the trachea. So what does that mean? It means that almost the entire length of the trachea, the posterior wall, is a membranous structure. So we need to remember that when we're inserting things like a tracheostomy tube that have sharp edges, because you can really damage the back wall and cause the tracheoesophageal fistula. So going back to the airway, and I promise we're almost done. Your fingers in that cricothyroid membrane, you feel that cricoid cartilage, and from there you can slide down and feel the tracheal rings. And tracheostomies are usually placed somewhere between the second and fourth tracheal rings. It can vary depending on a patient's anatomy. So that's the laryngeal handshake. I would encourage you to do the laryngeal handshake on your patients. Certainly if they're awake, offer to shake their hand first. But I say that as a joke, but not really. Arguably any patient we intubate, we should have palpated their neck to get a good understanding of their landmarks, because in an emergency, you don't have much time to work through that. So from there, and again, I don't want to make this too simple, but I think this is so important. And anytime I can teach about my own mistakes that I've made, either as a trainee or as a faculty member, I think it's good, because then hopefully you wouldn't make that same mistake. And so I want to talk about the physiology of airflow, because it certainly plays a role when you start working on patients with a trach in an emergency. So obviously we're all breathing through our nose and our mouth, which naturally humidifies the air that we breathe and sort of decontaminates it with the hair in our nose, the cilia, and our upper airway. And so then we obviously breathe down into our lungs, ventilate, oxygenate, and back out through the mouth. When we put in a cuffed tracheostomy tube, right, that is the only scenario if we inflate that balloon where we are now ventilating via the trach without a leak. So now you may try to breathe through your nose and mouth, but none of that air is going to get down into the lower airway and the lungs. This patient now with a cuffed trach tube inflated is now an obligate neck breather. So all air and ventilation is going in through the trach, down into the lungs, out through the trach. So let's think now about a patient who's a little stronger, right? They're off the ventilator. And now let's say we deflate that tracheostomy balloon. Now, some of the air from their mouth and nose will get beyond the trach down into the lungs. Some air will go in and out through the trach, but on exhalation, some of that air will go up through the vocal cords. And that is what can help a patient if they're weaning to the extent they can tolerate that from a respiratory muscle strength. They can now vibrate their cords and start to phonate. So when a patient has a cuffless trach or a cuffless fenestrated trach, which I'll show you a picture of, that enhances airflow up through the vocal cords and allows them to speak. Another thing that can help a patient speak, and we have Passy-Muir valves here in the US, and I assume there's something similar that you have, where you can pop on this one-way inspiratory valve on the end of the trach. And so now air can go in through the trach, and if the cuff is down, it can now go up through the vocal cords and back out the trach. So not back out the trach, all the air goes up through the vocal cords. So the mistake that I made, and you may encounter these speaking valves, these one-way inspiratory valves when you're caring for patients, and in an emergency, you would always just want to pop it off, right? So I had a patient who was in our step down, and I was a first-year fellow, and he was very stable. He had passed his swallow study, he'd been off the ventilator for days, and one of my favorite things is to have a patient get a Passy-Muir valve. And I thought he just had sort of a standard trach, and so I ordered a speech consult, because you need to do that at our institution at Cooper. and a passing mirror valve. And the speech therapist came and found me and said, look, we can't put on a passing mirror valve for this patient. And I said, oh, okay. Did he not tolerate it? And they said, no, he had a Bavona trach with an auto-inflating foam cuff. So if you would put, as I put a doctor's order in, a one-way inspiratory valve on a patient who had an inflated cuff or an auto-inflating cuff, essentially it doesn't deflate, essentially you're writing an order to, sort of smother the patient, right? So now air can get in, but it can't go out through the trach because it's a one-way valve and it can't get up through the cords. So really important to think through the nuance of, is the cuff up or down? Is there a cuff? Access from the upper airway is bag valve mask from above getting through below. As we go through the algorithm and some of the cases I have, I think that will become more apparent. It seems very simple, but again, when you're in an emergency, it can get a little more complicated when you've got two teams working on the airway. So that's sort of the physiology of airflow. So I want to spend a moment on equipment. And certainly, do you guys have any questions so far? I don't want to just breeze through everything. Feel free to interrupt. All right, so let's talk about equipment. And we have Shiley trachs at Cooper predominantly. I have no disclosures. It really doesn't matter the brand as long as we use sort of general terminology. And you see 3 pieces of equipment on the screen there. So the very upper piece, this is what we call the outer cannula. And probably most of you have had a trach in your hands before. And so you know that this is really rigid, right? Very different than an endotracheal tube. You can't bend it in half. And you might be able to crack it, but it's very rigid. And if you feel, and I encourage you to do this next time you're around a trach, the outer cannula, that distal end of it is very rigid. So when you scrape your finger across it, it kind of hurts. So that's important to remember when you're inserting this trach tube, that it is pretty sharp on that end of it. So this particular one, as in the one on the screen, has what we call a pilot balloon. So you know, whenever you see that pilot balloon, that this is a cuff trach, and that's a crucial piece of information because you need a balloon in order to ventilate a patient without a leak. So this is the pilot balloon that you inflate. This is the cuff. And this is what we call the neck plate. So it's kind of flexible and it gives you everything you need to know about the size and the type of the trach right on that neck plate. And this one says 6 DCT. So DCT simply stands for disposable cannula tube. And I'll get to that in a second. The 6 refers to the size. Now there's not perfect sort of correlation between all trach brands and size, but the Shiley trachs means that sort of the inner diameter with this inner cannula in place is around 6 millimeters. So the reason it's called a disposable cannula tube is because this inner cannula can pop in and out, right? We talked about the fact that when we have a trach, it bypasses the humidification of the upper airway. It also is a foreign body in the airway, so a lot of secretions form. It's one of the most common trach emergencies is simply to have obstruction of the tube. And so to prevent having to decannulate a patient to address that, you can simply pop out that inner cannula, clean it out. You should always have a backup trach at the bedside and either put a clean one in or clean it out and put that back in. So another sort of pearl is that at least with the trach brands we have, you cannot attach a bag valve mask to a trach tube with an inner cannula if the inner cannula is not in place. Can't tell you how many times I've had patients present to the ER in extremis having had removed their trach inner cannula, which is a problem because you can't really attach the bag valve mask. So you want to pop that inner cannula back in, and now you have it sitting inside the outer cannula. So what is this last piece? It's called an obturator. And at first glance, it just looks like a simple stylet, right? So unlike an endotracheal tube, we said that this isn't rigid. So it's the purpose of this stylet is to aid insertion of the trach, but it's not actually to allow the trach to hold its shape. So when you insert this, and you can hear it click in place, it actually protrudes out the back end of the trachea or the tracheostomy tube, and it's sort of this blunt structure that's less sharp and damaging to the back wall of the trachea, which is mucosal. So if you were to insert it, you simply pop it out and then pop this inner cannula in, and now you're ready to inflate your balloon and ventilate your patient. So this is simply the obturator. So if you're walking up to a patient in rapid response, you're in the ICU, you're running through this floor patient who was just discharged from your ICU yesterday or transferred to the floor, and this patient's in extremis, you'd like to know, if there's time, 4 pieces of information. The first 2, I would argue, you can get within 10 to 20 seconds. So the size. Every patient should have a backup trach at the bedside, but in scenarios where they don't, it's important to know if there's a size 4 in or a 6 in or was in, because you're not going to be able to get a size 8 Shiley or a different trach tube into a size 4 stoma. So sizing is important. You'd like to know the size, and remember, and you can see it on here, this is a size 6, which refers to really the inner diameter size. You'd like to know if it's cuffed or uncuffed, and you should be able to tell that from the doorway. If there's a pilot balloon, there's a cuff. Doesn't tell you if it's inflated, but there is a cuff that you should be able to inflate to ventilate with positive pressure if you need to. The next 2 are more optional, but you would like to know the reason that patient was trached. So were they failure to wean due to pneumonia, or did they have a large obstructing tumor that would prevent intubating from above? Do they have paralyzed vocal cords? Do they have subglottic stenosis? Are they a difficult airway? That's essentially what you're trying to get from that piece of information. And then if you can find out, you would like to know the date it was placed. And these last 2 pieces of information, maybe just asking, a student or the nurse who's not caring for the patient, can you just look up this information, because it is very crucial to know if you can figure it out. And so why is the date of placement so important? Well, it takes a stoma, which is simply a tracheocutaneous fistula, right? It's a skin and subcu opening that ideally a tract forms into the airway so that you don't then create a false passage when you insert an airway into it. So it takes about 7 to 10 days for that stoma to heal. So if you are encountering a trach patient in under 7 days, blindly reinserting that trach is very much risk creating a false passage, and we'll talk more about that. The other key piece to this stomal healing duration is that if you have to decannulate a patient during the course of an emergency, or they become decannulated, even a mature tract can close up to 50% in 12 hours and 90% within 24 hours. So really makes it important that once you stabilize your patient, if you had to intubate from above or remove the trach for any reason, you want to contact either the surgeon or the pulmonologist, the intensivist that placed it, because you very much would lose that airway and may need revision if you allow it to go several hours. So just to recap, these are some other brands and types of trachs up here. Jackson trach is a metal trach, no cuff there. Laryngectomy patients may have this. This is an example of a cuffless fenestrated trach. So again, more airflow up through the cords once patients are weaned off the vent. This is that one-way inspiratory valve. In an emergency, you want to pop that off. And this slide is just to make the point that when you encounter a patient and they're in respiratory failure and they have, let's say, a cuffless trach, you're going to need to exchange that trach and put in a cuff tube. And this is the only one that you can ventilate without a leak. Really important if you're managing trachs either on the floor or being called to rapid responses or codes, to know where you keep trachs. There should always be a backup trach that's cuffed of the same size or one side smaller at the bedside. But inherently, it's good to know in an emergency where you can find these. For us, we put them in our code cart. There's an airway drawer in our code cart. Whenever we have a patient admitted to the ICU or the step down, we place a phone call to supply, central supply, to also have a trach of their size at the bedside. So we're going to get into the algorithm very shortly, but I wanted to make this point. Does anyone know, what you want the cuff pressure to not exceed? I don't know how good the audio is here. So our respiratory therapists, by protocol, if they have a trach patient whose cuff is inflated, have to monitor that cuff pressure twice a shift. So, 4 times a day, essentially. And the number is important to remember, and I'll give you a good way to remember it. So you really don't want that cuff pressure. Oh, I just noticed the chat. Sorry if you guys are talking over chat. All right, so what's the best way of estimating the correct size of the tube? I'd say by going by that, that number in the right-hand corner of that neck plate. It can be off by a millimeter or so, but in general, if you're dealing with a size 6 Shiley, probably a 6 OET tube will fit. So usually we use that number that's on the neck plate as far as sizing goes. But getting back to this question, so the reason it's so important to monitor cuff pressure is that if you exceed the capillary perfusion pressure of the tracheal mucosa, you can start to cause ischemia to the mucosa, and you can eventually cause necrosis of the tracheal wall. And we all know what structure lies anterior to the tracheal wall. So the aorta and the innominate artery. Not to mention if you're eroding through the trachea, that's a bad complication on all fronts. So as far as an easy way to remember this, right, it's essentially creating a compartment syndrome. So if we think about our muscle compartments, orbital compartment syndrome, abdominal compartment syndrome, even ICP, in general, we want to keep that pressure below about 20 centimeters of water. So I think that number repeats itself in different compartments of the body for good reason. And it gets to what is the capillary perfusion pressure of that structure. And we don't want to exceed it, because when we do, we can malperfuse that organ. So just to make that point, if you ever get asked in a board question, 20 to 25 is a good number to go for. All right, so what are the emergencies we're going to encounter? This is an EM paper, but they're very similar in the critical care setting. Most common is dislodgement. We'll talk a lot about that. See infection as far as life-threatening complications, more so dislodgement, obstruction, and bleeding. You will also see, infection and stenosis. Most of the time, infection doesn't create an acute life threat unless mucus obstructs the airway. So let's talk about dislodgement. I mean, we can all recognize when a patient presents to the ED or they're in the step-down ICU and they're holding their trach tube's dislodged. It's totally decannulated. But there are more subtle presentations of dislodgement that can result in catastrophic airway emergencies. And I have this picture here because I think it displays, and we'll go through a case at the end, the risk that can happen, particularly if it's a fresh trach. So because there's that stomal opening, the soft tissue opening, and then the tracheal lumen is more distal, you can have a scenario where it can just sort of pop out from the tracheal lumen and then rest itself in the subcutaneous tissue. So you might walk up to the patient and their trach may look a little like this, or maybe protruding just a little bit, and no immediate signs, unless they're desaturating, that the trach tube is out. So it's not always obvious that you're in a false passage. And now if you ventilate with a bag valve mask, a trach tube that's in a false passage, you can create massive subacute emphysema, which can be a life-threatening emergency. So we'll talk about how to handle that. But this is an example of dislodgement. So I want to start going through the algorithm now, and we're going to go through the green algorithm and the red algorithm. The good news is they're the same algorithm, just the last step is different. It just matters whether the patient has a larynx or doesn't have a larynx, whether they have a patent upper airway. So there are 6 steps, but the step that I don't even talk about in the algorithm is the call for help. So this is a scenario, and as we'll talk about, it's best to have 2 teams operating, one at the upper airway and one at the lower airway. And we'll see why as we go through the algorithm. These are not scenarios where you're going to try to, you and a nurse just get through this patient and support the patient if possible. You would like to call for help from your team, perhaps even the surgical team or the interventional team that placed the trach. So what is the algorithm? So this algorithm was published a while ago now, and I've actually always looked for updates. This was published in Anesthesia by McGrath. You might recognize that as a brand name of laryngoscopes. But this is essentially the Difficult Airway Society guidelines for how to manage a tracheostomy emergency. So the first step, and you're looking at this box here, apply oxygen to the upper and the lower airway. So we want to both support oxygenation from above the mouth and nose as well as below. That is the default action in any patient with a trach who's decompensating. And the reason for that is when you encounter the patient, you don't know if their lower airway's patent, that tube or that stoma, if their upper airway's patent, and so that's why this is the default action. Now, if they're conscious and breathing, you can place high flow oxygen on both, and obviously set up a bag valve mask. You'd like to have 2 bag valve masks. If they're not conscious or not adequately breathing, then you want to ventilate from both above and below. So sealing with a bag valve mask here, and we'll talk about how to approach the trach in a moment. So your first step after you get high flow oxygen, you've got your bag valve masks to the bedside, is to remove that inner cannula. So like we said, a lot of times these just get obstructed. So pull that out, check if it's obstructed. If it's not, or it's clean already, The next step is actually to pass a suction catheter. So you can either do that just through the outer cannula or pop this back in and then suction. So sometimes that's just enough, right? If you have an obstructed inner cannula, pop it out, clean it, now your patient's doing better. If they're not, that next move of passing that suction catheter is both diagnostic and therapeutic. So diagnostic in the sense, if you insert it and you're only able to go a couple of centimeters, then there's something either your tube is obstructed or dislodged, because you should be able to insert it all the way. If on the flip side, you can insert it all the way and you suction and nothing really comes out, now you can be pretty assured, and obviously fiber optic would be the best way to confirm, but pretty assured that that tube is in place if you can insert a suction catheter all the way. If you're suctioning out and your patient's better, then great. Now you're on the right side of this algorithm and they're doing better. If not, after you pass that suction catheter, the next step is to deflate the cuff. And that doesn't seem right, right? So we just talked about the fact that the only trach tube you can use to ventilate a patient with respiratory failure is a cuff trach tube. So why would I want to take air out of this cuff? And this next picture shows you why. So if this tube is partially dislodged and malpositioned, could be placed just so, tipping forward, that that cuff is completely occluding the lumen of the trach. So by deflating that cuff and repositioning the airway, now you may be able to ventilate your patient. If your patient is not better after that step, the next step is actually to remove the tracheostomy tube. And I can tell you that for me personally, and I think probably most people listening, this is the most uncomfortable step in the algorithm, right? We think that there's some magic around these surgical airways, that they're secure. But the counter to that McGrath raises, and I actually directly quote him or the authors, is that when you are faced with a deteriorating patient with an obstructed airway, a non-functioning or dislodged trach tube offers you no benefit and can considerably harm your patient. So that fourth step of removing the airway is really uncomfortable for us, but it is a necessary step in the algorithm. And all of these steps, like, it takes a while to talk about them, right? But you can do this in a minute or seconds. Now we have no trach tube. Now we're in emergency oxygenation mode. We are bagging, so bag valve mask from above. We are bagging from below. So how do we bag a stoma? So couple options. For us in the ED, we have pretty quick access to a pediatric bag valve mask, which will seat very well around a stoma. When I'm in the ICU or on the floors, we have adult ICU. I don't see PICU patients. We don't have access to a pediatric bag valve mask as readily. So what you can use is a supraglottic airway. So any LMA or any supraglottic device that has that cuff on it, you can simply inflate the cuff a little bit, hold it down, seal it to the stoma, and then you can bag both from below as well as above. Now, once you're in that emergency oxygenation mode, now you got to intubate. You got to establish a definitive airway. In the green algorithm patient, you can either go oral tracheally, so from above, or from below. My preference is to go from below, but if this is either a fresh trach or you're concerned about the false passage, you can certainly intubate from above. And when you do that, now your trach tube should be out. If not, remove it. You can put some like gauze or Vaseline gauze over that site so you're not leaking. But once you inflate the balloon, the level of the balloon should be beyond the stoma, and you shouldn't be leaking after placement of an oral tracheal tube. So if you're most comfortable intubating in these very sort of urgent and life-threatening scenarios, the SATs are dropping, absolutely perform RSI and intubate orally. You can intubate from above. The other option, particularly if you have a well-granulated stoma, is to intubate the stoma. And this is where it's really important to have that backup trach tube at the bedside or a 6-OET tube. And positioning is everything. And that's part of the reason I walk you through the laryngeal handshake. You know, I've even seen our ENT residents try to do this in an upright patient or a semi-recumbent patient. And really, you should be all the way supine in that sniffing position to really open up the airway. And I pulled this picture from Google, and I always joke about the fact that we don't have sandbags readily available, but you can use a blanket, anything, towel roll to sort of extend that neck and open up that airway. Bright lights are good here. Don't want to be doing this in the dark. And then, inserting sort of at a 90-degree angle, just inserting that trach tube, you'd have your obturator in and kind of going through and placing it. Now, the red algorithm, this is slightly different, and these are laryngectomy patients. And whenever I talk to our fellows, I always ask them, you know, like, who likes to intubate? And almost everyone in the room raises their hand. And then I ask them, like, who could intubate this patient who's had a laryngectomy? And about half the room will typically raise their hand, which is in line with a published study of critical care trainees. And I can tell you, if I was in my first year of fellowship, I'd be raising my hand again. I can intubate, confident in my airway skills. I don't know that I was, but I would raise my hand as, oh, I could try to intubate that patient. And 50% of respondents of critical care trainees would say, yes, I can intubate a laryngectomy patient. But the reality is that 100% of the time, if you insert a tube into the mouth of a patient who's had a laryngectomy, it ends in the stomach. So what happened was when they surgically resect the proximal trachea and the larynx, they actually pull through the distal trachea to create that permanent stoma. And so the mouth is only connected to the esophagus and stomach. There is no connection to the airway via the oral route. So that's why the algorithm is different for laryngectomy patients. And now the good news is that patients with a laryngectomy only have the stoma that you can intubate, but it's typically very straightforward because it's a surgically created opening. And the other good news is that this is only about 3 to 5% of patients who've had a trach have had a laryngectomy, and usually you would know that. Not saying in every scenario in an emergency you would know that, but oftentimes these patients should be labeled, you know, with airway signs that they have had a laryngectomy. So you can see in this picture, this is a provider using a pediatric bag valve mask, and they're ventilating the stoma. So this is what emergency oxygenation looks like in a laryngectomy patient, and arguably a tracheostomy patient who you've decannulated the trach moving through the algorithm. So what is the red algorithm? It is exactly the green algorithm until the last step. Now, we spoke about the first step being to support oxygenation and ventilation from both the upper airway and lower airway in every trach patient. If you absolutely knew that your patient had had a laryngectomy, you do not have to ventilate from above because you are insufflating the stomach. Again, this is a very minority of patients are going to have had a laryngectomy, but if you knew they had, you could just focus on supporting oxygenation and ventilation via the trach or the stoma. All the other steps are the same. So if they've got a trach tube in place, you're going to want to remove it, clean it out, replace it. If they're not better, you want to pass that suction catheter, get a sense of, can you pass it all the way? You try to suction out the airway, they're still not better. That next step, you want to deflate that tracheostomy cuff, reposition the tube, reinflate the cuff. And now if they're still not better, you want to remove that trach tube, because remember that an obstructed or dislodged trach tube is a potential harm to your patient and certainly not benefiting. Now you're in emergency oxygenation mode. You're bagging that stoma either with a pediatric bag valve mask or an LMA connected to an adult bag valve mask. And then from there, you got to intubate, but you have to intubate the stoma. Now you can either use a trach tube or an endotracheal tube, but you have to intubate the stoma. And usually we recommend starting with a 6.0 ET tube if you're going to use that. And it's really important because you're bypassing most of the upper airway to not insert that tube too far. So if you have an endotracheal tube because you don't have a trach tube immediately handy, the trick is that you want to insert it until you just don't see the cuff. Just until you lose sight of that cuff, then you can inflate the cuff. Otherwise, you're likely to sort of main stem the patient, which could create an issue. All right, so I only bring this up briefly. I don't think this is a major thing you need to focus on, but I've encountered it. Patients with a laryngectomy sometimes will have a TEP, which is essentially a tracheoesophageal voice prosthesis. All it is a one-way valve that is where intentionally an ENT surgeon creates a little opening through that posterior shear wall of the esophagus and trachea, and they insert this, this valve. And so what happens is that air, when the patient inspires, can flow through that little valve into the sort of esophageal and pharyngeal tissues. And as that patient exhales, they can actually phonate or create sort of a voice through the vibration of the soft tissue as the air is expelled through the one-way valve up the esophagus. So this is just a voice prosthesis. The reason I bring it up is during COVID, we had a woman who'd had a laryngectomy like 20 years ago, didn't have a tube in. She moved to our unit. She was on high flow O2 and, sort of a trach collar scenario. And we knew that we had to get her on positive pressure. We had to ventilate her. And when I looked in her airway, I saw that. And I've seen these a few times. And I got worried that when she wasn't in extremis, we had a little bit of time, that I would potentially dislodge that when I put in a cuffed tracheostomy tube, because she had no tube in place, just in general. And that was, she just had a permanent stoma. So I called ENT and they came to the bedside and they said, you really don't need to worry about it. So, you obviously don't want to just errantly put a trach tube in, but we inserted it, kept the TEP in place. We didn't touch that. It didn't get dislodged in the airway. So in general, I think that you don't need to worry about that. This is just another example of how the TEP works. As they exhale, it puts air through the vibrating tissues here. They have a little sort of speaking valve on the outside. All right, so that is the algorithm. And I just want to touch on bleeding for a moment, because these can be life-threatening events, these bleeding tracheostomy tubes. So the good news is, similar to other tracheostomy complications, most bleeding occurs within the first 48 hours of trach placement and is pretty minor, right? So mucosal bleeding, little lido and epi or cautery, subcutaneous bleeding, just stomal bleeding is often the cause. Sometimes the inferior thyroid veins, which aren't shown here on the arterial circulation, can get nicked and they can bleed. Clearly, we're all worried about an arterial source of bleeding. About 3 weeks ago, one of our post-ECMO patients, who's now decannulated off ECMO but is still on the vent, developed, we didn't know it, he started having massive red blood from his trach site in the middle of the night, because it's always the middle of the night. It turned out he had an inferior thyroid artery aneurysm that had ruptured. So the team did a great job. They were able to sort of suction out the airway. You can still use the same algorithm when you're approaching, establishing a patent airway. They were able to keep the trach tube in place and stabilize him enough by sort of packing the mouth and the upper airway that they got him to neuro IR and they were able to embolize it, and he didn't bleed again. It was great. But the other complication, other arterial source, and I'm sure you're all thinking about, is the most feared complication as far as hemorrhage goes, and that's a tracheoinnominate fistula or a TI fistula. And if we think about why this happens, right? So we talked a lot about cuff pressures. This is the reason you don't want high cuff pressures for prolonged periods of time. You can see that the cuff is overinflated here. It is pushing on the anterior wall of the trachea, and if it erodes through that wall of the trachea, you can then penetrate that innominate artery that slides right over that lower portion of the trachea. Because remember, your stoma is up here at like the third or fourth tracheal ring, but your balloon falls down here. So depending on how their anatomy is, that balloon can sit right exactly sort of in the trachea, right near where that innominate artery crosses over. Now, the mortality of patients with a TI fistula hemorrhage is probably 80 to 90%. Good news is that less than 1% of patients develop this complication, but when it happens, it is catastrophic and almost uniformly fatal. When does it happen? And I think this is important to remember, although patients don't necessarily read a textbook, usually between 3 days and 3 weeks. I've only ever seen this once, and it was a lady that came over from LTAC. She was a post-CABG patient for bleeding, and of course she arrives not bleeding. And I bring up this example because I think it's important, because half of patients who have a TI fistula will have what's called a sentinel bleed, where they have some bleeding that might be a little scary, not so scary, before the actual life-threatening hemorrhage. And that was what happened. So she didn't really bleed. Can't remember exactly what was done during the day, whether ideally any bleeding you investigate with fiber optics, with the CTA of the head and neck. I don't remember specifically how it was investigated. CTA is not perfectly sensitive for TI fistulas, but in the middle of the night, she hemorrhaged, and it was. So these patients don't usually die from hemorrhagic shock, although they lose a lot of blood. It's usually asphyxiation. So it contaminates the airway and can very often be a fatal complication, which unfortunately it was for her. Attempts at resuscitation were made and she did not survive. And that was both the amount of bleeding and that whole case was very eye-opening to me. And if anyone in the room has seen this, you don't have to, you're not exaggerating when you see these patients. So what do you do? Now, most of this is sort of a Band-Aid, for definitive management, this phone is call up your friends who are thoracic surgeons, ENT surgeons. These patients need to get to the OR. There are some cases where if you might be able to tamponade, you might be able to get them to IR, but most of this is, if it's going to be managed definitively, it's going to be surgically. So what do? Well, the first step is to try to tamponade. And so just like in the trach algorithm where you feel like you're doing something you shouldn't, the first step is to overinflate that balloon. And you can put, I think, upwards of like 30 to 50 cc's in these tracheostomy cuffs. So in an emergency, for a short period, you want to inflate that cuff because you'd like it to tamponade that innominate artery. If that's successful, great. You still need definitive management. If it's not, you're going to need to remove that trach tube in order to apply digital pressure. Now, if you're going to be removing the trach tube, you need to intubate from above, ideally. So you're going to intubate from above, then remove that trach tube, and then you're going to try to slide your finger into the stoma and push it forward and pinch it against your thumb. You are literally trying to pinch the innominate artery from, you have tracheal access, so you're pushing on the anterior wall of the trachea into your thumb to try to pinch off the innominate and get hemostasis. I throw this on here, this isn't even adequate. This picture in no way conveys reality. There's blood everywhere. You can't visualize. So these are very life-threatening situations. So that is that. I'm gonna jump into cases. I have 2 cases, which I think we have time for both, if you guys are up for both. I just wanna make sure, are there any questions so far? I got the chat open now, sorry. Yeah.
Could I ask, is there any situation where you would not go for tracheostomy? Like any contraindications that you may have come across?
Oh, like you have an intubated patient and you can't do a trach?
Yeah.
Like where you wouldn't trach? Well, I mean, for us, more often it comes up in a scenario where, you know, the family's struggling, the patient is relatively moribund, and they're not looking like they're going to recover or wean off the ventilator, they're comatose, and it just sort of feels like futile care. As to whether a patient can't be trached, I'm sure there are some ENT scenarios with a mass obstructing where you can't do it. I've not encountered clinically where, you know, with surgical consultation, most of our trachs are done by our interventional pulmonologist, which you might remember from being here, but anyone with sort of non-palpable landmarks, morbidly obese, head and neck tumors, either ENT or acute care surgery will take. And I've had, you know, it's an elective procedure, right? So obviously if their ventilator requirements are too high, it's not the right time to do it, or they can't get it. There was one scenario where we had a patient who was chronically critically ill, chronically on vasopressors and dialysis and thrombocytopenic, where all the teams just said too high risk. And they didn't do it. And ultimately she sort of died of other reasons, and she was intubated for like 5 weeks. I mean, we were very long on event days. That's the only scenario I can remember in the past, like, I don't know. I've been at Cooper for 13 years. I seem to have drawn all over my slide here. So I think I'll jump into the cases if that works. This first case is, these are both very real patients. One patient I encountered in 2011 during my fellowship. And if you remember, this paper was published in 2012. And part of the reason I give this talk is because I felt very lost in managing this decompensating patient. And I did not have an algorithmic approach. So that's this case. And the second case actually happened 2 weeks ago in our ICU. And it was a really tough case. So I thought it'd be good to present that one as well, if you guys are up for 2 of them. So this first case, unfortunately, Camden, New Jersey, where I work, there is a lot of opioid use, and there are a lot of overdose patients that we treat in our emergency department. This again was 12 years ago. So at the time, heroin was widely used. Now it's more fentanyl. You know, we're very close to Philadelphia, and unfortunately, there is a lot of substance use, and we have a lot of efforts in our ED to sort of treat these patients with Suboxone and try that. We have great addiction medicine support. So I'll sort of have this as a background. And this unfortunate young gentleman was injecting heroin. He actually, when EMS found him, he had a syringe in his arm. He was overdosed in PA arrest and hypoxic, and they intubated in the field and brought him in, and he had a very prolonged downtime of arrest. So suffered very severe brain injury. And I was actually as a fellow, I had cared for him in the ICU, was in there for several weeks. His family was just having a lot of trouble, thinking through trach or not trach, and he really didn't have any meaningful neurologic recovery, but his mother just, really felt that she couldn't remove the life support. And so he underwent trach. And this happened about 3 weeks later or so in our intermediate care unit, which is our step down ICU. And I was a fellow, and I was called into the room, and the patient the nurse said he's hypoxic and he's in respiratory distress. And I walk in, he's very tachypnic. At the time he was on the ventilator, just on 40% FiO2. So I cranked that up. He's having sort of a low grade fever. It was not saturating well. It was in the 80s. He was very tachycardic. He was normotensive. And, look at the airway, right? So get your information right away. It's a size 8 trach. There's a pilot balloon. It's cuffed. Looks like it's in place as far as flush with the neck. But he's very tachypnic. He's using accessory muscles, and neurologically he was kind of comatose and unresponsive, but I knew that to be his baseline neuro exam. All right, so if I can, and I don't know if you want to, and if this doesn't work, it's okay, but if anyone wants to shout out, what are you going to do here? What's your next move? Start the algorithm, right? So you want to oxygenate from above and below. And for this guy, we want to use a bag valve mask, so 2 bag valve masks. And so you start to support him, disconnect him from the vent, you're bagging him. And then the next step.
Remove the cannula.
Very good. So you pop out that inner cannula, looks clean. And I'm telling you exactly what happened in that scenario. It was totally clean, no issue. What I will say is, I remember what happened. I didn't go in this order. I did not have a smooth approach to this patient, but we did end up removing the cannula. Nothing there. So what's your next step?
Pass the tube.
Pass that suction catheter. Yep. So diagnostic and therapeutic. You can pass it all the way to 10 centimeters, hub it, get a ton of secretions back, suction out the airway, and put that inner cannula back in and start bagging. He's easy to bag. Seems to be doing a lot better. So SATs come up, and at this point I'm thinking, this is great, right? Because I'm not comfortable with trachs in my 3rd month, I think, of fellowship. So we have good compliance with bag valve masks. The SATs are good. Get him back on the vent. He seems to be doing okay initially. And we're on a big sepsis push. So just pointing out he has tachycardia and a low grade fever. So we have a sepsis order set. So gave him some fluids, heart rate's better, walking away thinking, you're nailing critical care fellowship, and then literally within 2 minutes, call back to the room. SATs are now 80% again. So a little more hypertensive this time, using accessory muscles, desaturating, very tachycardic. He's in sinus tach. So what are we going to do? Run the algorithm again. You can keep running the algorithm, right? So we're going to support oxygenation from above and below. This is actually a picture of him. I took it at a later date. He was a frequent patient of ours. So we want to pop out that cannula, right? So we pop out that cannula, nothing on it, totally clean. Let's say we reinsert a clean one, pop it back in, bagging, good compliance, but really not doing better. So now we're passing the suction catheter. You can pass it all the way in. Don't really get much out. He's still labored, still in distress, and you're having to support him with bag valve mask. So now what's the next step?
Deflate the cuff.
Very good. So you want to deflate that cuff and make sure you're not malpositioned. So you reposition the trach, reinflate that cuff, and you do that. You're putting air in. It doesn't seem to be getting better. Now what?
Remove the cannula.
Very good. So in this scenario, we were like 3 weeks out. And I remember the trauma surgeon being there. Back when I was a fellow, trauma surgery did all our trachs. And we decided, because it was relatively fresh, and this was before we had, bedside fiber optic ambuscopes, like just, within, an arm's reach. So we didn't have immediate access to fiber optic. And so, we were pretty certain we had color change, like we were ventilating some. And so we put it actually in an NG tube. You could use a more rigid sort of airway stylet, but just be real careful with that back wall of the trach, or the tracheostomy, or the trachea, I apologize, because you can penetrate that back wall. So we placed an NG tube, slid it over, put on a new cuff, inflated the cuff, and he was doing great. So I will tell you in the moment, there was a little more information, and some of it I tried to capture here. I think Dr. Molandino likes ventilator waveforms. So you're seeing we have serval eye ventilators, pressure, flow, and volume. Does anyone, here, I'll give you a still shot. Does anyone notice anything here? So when you walk up to your patient, always glance at, you're going to work through your algorithm, but look at all the information in the room. You're looking at the monitor, you're looking at the patient, look at the ventilator screen too. Does anyone see? So if you get, so this is the volume scaler here, the volume tracing, this blue line at the bottom, what goes in should come back out. So you got the inspiratory limb, and I don't know that you can see my pointer here, but at the bottom tracing there, you should come up and form a triangle and come all the way down. You can see here, there looks like there's evidence of a leak. And if you look at the inhaled, exhaled tidal volumes, there's a big discrepancy. And I will tell you that I did eventually, a few minutes into resuscitation, realize that it was pretty noisy as we were bagging him. So he had a cuff trach tube, but you always want to listen. And there was evidence of it with his ventilator waveforms. This was simply a case of cuff rupture. Now, did you have to figure that out to fix it? No, right? So even if you didn't realize the cuff was blown, you went through the steps of the algorithm. The last step is you got to replace the trach tube. I always make the joke that this is not my daughter. I do have 3 kids, but every kid feels this way about broken balloons or pop balloons. So this is not my daughter, but it could be. So this was simply a case of cuff rupture, which I didn't really figure out the first resuscitation of him. And then going back in, we eventually figured out what was going on. But when you use the algorithm, you fix the problem even if you don't exactly figure it out. My kids are in middle school now, but see, this is just to prove that they love balloons. All right, so I would like to do this case. Is it okay if we do? It should be done by in less than 10 minutes. You good to do one more case?
Yeah,
okay.
Yep.
So I'm sorry it's a little hard to make this interactive, because I think it's good to sort of think of like, what would I do? Like picture yourself in the room. So I was sitting in our attending office. I was actually about to go home for the day. It was like 5 or 6 o'clock. And someone ran in and said, the patient in ICU 29 is hypoxic. And they had, so I had been in the office when the surgeon, the endocrine surgeon, I didn't know this was the same patient, had come in and showed us a picture of this massive goiter that they had removed. And because they were worried about the recurrent laryngeal nerve, and also just because of the sort of worried about the distortion of her airway because it had been so large, they trached her in the OR. That was less than an hour ago. So I run into this room and see that the SATs are 70%. And within a minute or two of being in there, the nurse at the bedside is like, this patient just came out of the OR. They had a thyroidectomy. And I thought, oh no, this is like, talk about a fresh trach. This patient's been in the room for 20 minutes. So I will go through and point out the things that I think went well and the things I don't think went well. I vividly remember when I walked in the room, because I was the first one there, second, the respiratory therapist was bagging the patient, and she had just grabbed the bag and she had administered maybe 3 breaths. And I ran and I looked at it, and the neck, like around the chest, was sort of swelling up. And so what would you do in that scenario? If anyone wants to comment. So we talked about the default action. This is why I think it's always good to go over cases, because there are caveats to some of these cases. That swelling is sub-Q emphysema. And I've been giving this talk for 8 years, and every year I give it, I show this picture of this case report and chest. And all I could think about was when I saw that swelling of the chest and palpated it and knew it was crepitus, like this trach is out, it is dislodged, and immediately you need to stop bagging. Because if you keep bagging a trach tube that's dislodged in a false passage that's causing sub-Q emphysema, and you can see on this x-ray, there's sub-Q emphysema all along the neck, it goes all along like the shoulder area, the latissimus dorsi, all of that soft tissue has air in it. And there are bilateral pneumothoraces with deep sulcus and tension. So this is the scenario you can create, and I will show you her x-ray. And again, she only got like 4 or 5 breaths, but how much air can you ventilate with a bag valve mask? It's like 500 cc's to a liter, depending on how hard you squeeze. And so you can, if you look at this patient's face, he looks morbidly obese, but this is actually all air. He's got air up to his eyeballs, air around the neck. And so you can create a scenario where now not only do you have a trach emergency, whether it's obstruction, dislodgement, or whatever it is, but now you're causing massive subacute emphysema that can make it unintubatable from a stomal perspective. And I've even seen it be so massive that it's hard to intubate from above. So what happened here is this patient just simply coughed, and I'll kind of give you information I didn't learn until after the resuscitation. She had a very thick neck and had that goiter, and they had not used an XLT trach, and I'll show you a slide on extra long trachs in a moment, which essentially gives you a longer horizontal part to the trach to get into the airway. So if you have a patient with a thick neck or who's obese or thrashing, it's really easy for that freshly placed tube just pop out of that tracheal lumen and then get jammed down into a false passage, which is what happened to her. So what are the indications that, like, how did we know that right away? So one, she told me when she walked in, the low minute ventilation alarm was going off. Well, that's because air was not getting into the lungs. It was in the false passage. So, and then when you bag, you probably will encounter some resistance. And if you ever start to see, swelling, that crepitus or that subacute emphysema building up, you want to stop. The patient will rapidly desaturate, clearly, because their airway is not being utilized. You're not oxygenating them. And usually the trach tube wouldn't be totally flush with the neck, although I don't think that's a completely reliable way of figuring this out. But you just want to stop. If you see the development of subacute emphysema, I would focus all the way on upper airway oxygenation and ventilation. So we did that, and I will take you through kind of what happened, because there were some things that didn't go great. So I thought that went well. We quickly recognized we were in a false passage. So in my mind, we were starting from a position of trach is out, right? So we're already at the last step of the algorithm. So we're not gonna take out the inner cannula, take all this time to pass the suction. I already know we're out. So we're at this stage where the trach tube has been functionally removed. So now, and had retention sutures, so it was sort of still in the false passage, but not in the airway. So we were in emergency oxygenation mode. We were not intentionally not bagging the stoma, not bagging that tube that was dislodged. We were bagging from above, and fortunately, get an oral airway in, she was easily baggable. So the plan then was to establish definitive access from above. The first attempt at DL was unsuccessful. She had a pretty hard airway. She was a larger woman, and it was just difficult visualization. Her SATs had recovered with bag valve mask, but just a difficult scenario. So the first intubation attempt was not successful. Bagged her back up. She didn't really desaturate too much with that. Then passed the tube under video laryngoscopy. But the surgical team all along is sort of, now we have the ambuloscope in the room, and they had scoped, and they were able to reseat the trach. So they got the trach in and confirmed visually, and we had intubated from above. And this is where the reason I bring up this case is because these two teams have to be talking. In my mind, I can't remember when I think they did tell us, like, we reinserted the airway, but that wasn't really going through my mind. So now we go to bag, and it's like kind of hard to bag, and the SATs aren't coming up, and we don't have a good color change, yet we saw it go through the cords. And so in those scenarios, right, your SATs are rapidly dropping. It's hard to always sort of think big picture. And in my mind, I was thinking, well, the tube must not be in, because we could bag easily before. So we removed the endotracheal tube. And now I think anesthesia had come, they intubated from above, and around the same time, we figured out that the lower airway team had reinflated the cuff. Because in between removing that breathing tube, she was even hard to bag just by bag valve mask. In fact, we even inserted an LMA and couldn't bag her. And so all this is happening in seconds, but the crucial thing that happened was that trach cuff the cuff had been replaced, and the cuff had been inflated, which, if you're thinking through this logically and both teams are talking to each other, that shouldn't have happened. So when we realized that, we deflated the cuff. We were now able to, the tube is in, we're definitive airway is oral tracheal, and they took her to the OR to place a proximal XLT trach to make it be long enough that it wouldn't get dislodged. So The reason I bring up this case is I think it went very well recognizing dislodgement immediately, abandoning bag valve mask when you're in a false passage, oxygenating and ventilating from above, intubating from above. But because throughout the course of resuscitation, there was this pressure from the surgical team thinking, I got to get this trach back in because this lady is going to be, the reason they tricked her in part was they thought it'd be so hard to go back in after scar tissue and the big surgery that she'd had. So that was a unique scenario where we kind of had two access points, and we should not have had that tracheostomy tube balloon inflated. So fortunately, she did desaturate, she did not code, and we were able to get the endotracheal tube in. And this is just to explain, and this is actually, I think, my last slide, the difference in an XLT trach. You can kind of think about it like a candy cane, right? So the part that's outside the body is this top part of the candy cane. And an XLT is simply extra long tube. It's got extra length. So if you have a patient with a thick neck, you need this horizontal distance to be longer so that you can get all the way to the tracheal lumen. If a patient has like tracheomalacia or the balloon's not seeing well, sometimes we'll do what's called a distal XLT, which means the vertical length is longer. But if you have a patient that needs an extra long trach, like you have to use it. And this is a great example. The whole reason this emergency happened really was because she had a regular size 6 Shiley and not a proximal XLT. And I show you this x-ray. This is the last slide before the summary slide. I don't know why all these lines are on here, but this is really important to look at. Remember, she only got bagged a few times. Now, granted, the vent may have delivered some air before it was discovered, but you can see all this subacute emphysema in her neck. And this is with just a few bag valve mask breaths. And then you can see she has pneumopericardium. She did fine from the pneumomediastinum standpoint, but just makes the point to, once you recognize a dislodged trach and subacute emphysema, stop bagging through that dislodged trach tube. So just, in summary, to conclude, I'm sorry I went a couple minutes over, but, relax. It's not easy, but think through the algorithm, take it one step at a time. You're an intensivist, you do airway, and trach patients are simply patients with 2 airways, which makes it more complicated, actually. So think through the algorithm, right? So you want to oxygenate and ventilate both the upper and lower airway unless the patient's spontaneously breathing. You want to remove that inner cannula and figure out, is it just obstructed? If not, reinsert it, bag them if they're not better, pass that suction catheter all the way in. If you're only hitting a couple centimeters in, you're going to probably work through the rest of the algorithm. If you're inserted all the way and they get better, well, that's great. If not, deflate that cuff, reposition that tube, reinflate, bag them, still not better. Now you're in the step of, you got to get that trach out. Emergency oxygenation, ventilate from above and below. We talked about the tools you can use to do that. And then in the non-laryngectomy patient, the green algorithm patient, you either intubate orally if you're most comfortable with that, or you can intubate the stoma, but have fiber optic available if it's a fresh stoma less than 7 days. If it, like this patient, this is why we intubated from above. 1, because we were in a false passage, but 2, in a trach that's only about 30 minutes old, I was not going to try to intubate the stoma. She followed commands the next day. I went and examined her, and she actually did very well, but she almost died during that event. It was very, very stressful. And I go through this algorithm year after year, and this only comes up clinically once or twice a year. And even that, it was extremely stressful scenario because we just simply couldn't bag her after the first airway attempt because the cuff was inflated. All right, so these are just finishing up. Remember that stomal healing period is about 1 to 2 weeks. So you want to have video laryngoscopy available, and always, always, always have a backup trach at the bedside. And I am happy to take questions. Sorry I went over, and I understand if there's not time.
Thank you. Thank you, Dr. Damuth, for that.
Yeah.
Great talk. Yeah. Especially with the case scenarios at the end, really put things into context for us. Yeah, if anyone has any questions, feel free to unmute yourself. We can use a few minutes before we end. Yeah.
Is it 5? Is it 6 o'clock? What time is it?
Yeah, 6 o'clock. Yeah.
6 o'clock.
Maybe I could ask one question. So,
Yeah.
most of the patients that we see here for tracheostomy are those who are in the ICU for long-term stay, maybe difficult to wean off. How would you, or is there any need to change your ventilation strategy when somebody is on long-term tracheostomy?
Yeah, that's a really good question. And I really like mechanical ventilation. I think that that's an area that we, in critical care haven't completely figured out. And I think part of it is that many, particularly our patients in our acute care hospital, they may have a period of time with a trach in our ICU and in our step down, but oftentimes they're more quickly sort of going to long-term acute care hospitals. And so I don't think there's good data to guide us on, we tend to use sort of expanding duration of pressure support trials and trying to get to a place where a patient can go hours at a time, and then expanding their sort of exercise capacity to where they can maybe make it the whole day, and then they're just getting ventilated at night. But as far as and then I'm sure we've all seen scenarios where you kind of push someone and they go 4 hours on pressure support, and then the next day they can't do any pressure support, right? So I don't think we know the answer to that. But in general, I think that our goals change in the sense that if you've gotten to the stage of elective trach, you're probably not in the throes of early ARDS. And so now I think you can focus more on trying to handle patient ventilator asynchrony, which pressure support is often a good mode for, allowing them to be more comfortable, more wakeful. So yes, their tidal volumes may be bigger. They're sort of exercising their muscles of respiration, allowing them to trigger. So not having them as assist control such that they're like not triggering the ventilator because they have diaphragmatic dysfunction. So I think encouraging spontaneous breathing, it seems as though the literature supports that, as far as re-exercising the diaphragm and kind of rebuilding their ability to ventilate. But as far as formulas for how much and how long, and I don't think we have a good understanding of, and I think every patient's different too, right? Like some patients you can push them and they handle it, and other times, like I said, you go 2 hours and then the next day they can't do anything for 3 days. So I don't have a good answer to your question, but in general, I think our approach is to get more to spontaneous breathing and worry less about rigid lung protection, deep sedation, etc.
Thank you. We have one question in the chat. Who should do tracheostomy in the ICUs? ENT surgeons or intensivists?
I guess that depends on where you work and who you are. I don't know the answer to this. The complication rate is pretty similar for open versus percutaneous. I think ideally it's done in high volume. So with most interventional procedures, it wouldn't be good to sort of have people dabbling in it and doing it infrequently. Most of ours that aren't anatomically difficult are done by interventional pulmonary because they're kind of part of our pulm crit care group. So it's a little bit political in that sense. But I think there's some maybe support for a percutaneous approach when it's feasible. Now, there are a lot of reasons that it might not be feasible, right? The coagulopathic patient or relatively coagulopathic patient, the patient with inadequate landmarks or a tumor. So we use all 3 service lines. The straightforward trachs with percutaneous landmarks that don't have abnormal anatomy, those are pretty much all percutaneous at our institution. Where you might need more access to cautery if you're worried about bleeding. So our ECMO patients will often, because they're like a bleeding risk, will often get surgical trachs so they can open and cautery if needed. But I don't know that there's an answer to that. ENT at our institution, I think it's really institution dependent. They're so busy that doing all routine trachs would probably overwhelm their OR capacity, and we have to wait a long time, which isn't good for anyone, right? You want to get them trached once you decide they need it, ideally doing it faster. So I think they're all capable, and it's really institutionally dependent. But in general, we kind of go for perc trachs at the bedside. Usually our IP team can do them within 24 hours. So that's usually what we do. But I don't know that there's an evidence-based answer to that either.
Right. Yeah, always a tough question here. I just want to share this for everyone in case you may have not come across it, but we are having a critical care conference happening in Dar es Salaam, and we're calling it AfriCrit. It's less than a month away, and we have conference talks, we have workshops. One of the workshops is airway, so we'll definitely be talking about tracheostomy there as well. So yeah, I mean, if you are interested, and definitely you can register. There's still some seats remaining. We have around 15 speakers coming for the conference, so it's going to be great, and there's going to lots to learn, lots of skills and procedures to also like practice on simulation, including ultrasound as well. So yeah, you're welcome to register. We have this website. I will put it in the chat, and I'll send it to everyone as well.